morning. It's an honor to be here. Of course, I would have loved to be in beautiful Copenhagen with all of you today. Thanks Diabesity Working Group for keeping this interesting conference despite the circumstances. Renal functional reserve is defined as the capacity of the kidney to compensate or increase its function in states of high demand, such as high protein or fluid intake, pregnancy, overweight or obesity, loss of nephron caused by kidney disease, or insufficient nephron endowment. Kidney mechanisms to achieve this end is increasing glomerular pressure. This mechanism is called hyperfiltration. Just a reminder, half of population has 1 million nephron in each kidney, or even more, but the other half has less than 1 million, and 14% of population have less than 500,000 nephrons, so they are hyperfiltrating even without high demand situation. From this point of view, hyperfiltration is a physiologic compensatory mechanism, but we know that hyperfiltration keeping in time induces direct endothelial cell damage, increasing wall stress that may cause detachment and podocyte loss, an increased strain on the messenger cells that can stimulate them to produce cytokines and extracellular matrix. Paradoxically, a physiologic mechanism causes a vicious cycle of further nephron loss, and this damage is perpetuated even when the underlying cause of the disease is treated and disappears. There are several interconnected mechanisms that are involved in the progression of CKD, including hemodynamic and non-hemodynamic changes. The first occur in glomeruli involving an increased glomerular capillary hydrostatic pressure, an increased single nephron glomerular filtration load, inducing glomerular injury and indirectly tubular injury. Different factors have been involved in hyperfiltration process. In general, any factor that causes a reduction of afferent arteriolar resistance or any factor that increases efferent arteriolar resistance could rise interglomerular pressure and induce hyperfiltration. In the last situation, ACE inhibitor or ARB blockade angiotensin effect and eventually limit efferent vasoconstriction and therefore limit hyperfiltration. Several clinical trials have demonstrated that both renin-angiotensin-aldosterone system inhibitors reduce the loss of GFR in the long term. The main mechanism of their action is based on the reduction of interglomerular pressure. Therefore, proteinuric CKD achieve the most benefit from these therapies. RAS blockade with ACE inhibitors or ARB is the cornerstone therapy to reduce proteinuria, CKD progression, and cardiovascular risk. These benefits appear to be comparable between ACE inhibitors and ARBs when they are used in equivalent doses and carry comparable adverse event besides cough, which is exclusive to ACE inhibitor. RAS blockade has been shown to be renoprotective in diabetic patients with over nephropathy as well as in non-diabetic CKD. I'm not going to bore you with all clinical trials that show that ARB or ACE inhibitors are effective in protecting against the progression of CKD due to diabetic or not diabetic proteinuric CKD, and this protection was independent of the reduction in blood pressure. So we know that 2 decades ago. In the coming slides, I would like to explore some specific issues to answer the question regarding whether we can optimize RAS blockade treatment. So in the next slide, we will attempt to answer the following question. Higher than the maximum antihypertensive dose may afford additional renoprotection. ACE inhibitors and ARB effect is comparable. The inhibition of RAS system at several different steps of the pathway would lead to a more complete inhibition and therefore to maximize the renoprotective effect of RAS blockade. Can we confirm that the previous conclusion for the clinical trials can be extended to a specific population, such as age population or advanced CKD population? We should be aware of both as usually excluded in clinical trials. And finally, have ACE inhibitor and ARB an additional effect beyond hemodynamic effect? So let's move on to the first question. There is an increasing body of evidence which shows that RAS blockade at dose higher than the maximum antihypertensive dose may afford additional renal protection. In the SMART study, 269 patients who had persistent proteinuria higher than 1 gram per day, despite 7 weeks of treatment with 16 milligrams per day of candesartan, were randomized to receive candesartan at a dose of 16, 64, or 128 milligrams per day. After 30 weeks, the maximal dose of candesartan 128 mg per day achieved an additional decrease in proteinuria of 33%. Reduction in blood pressure were not different across the 3 treatment groups, although elevated serum kaliemia levels, kaliemia higher than 5.5 milliequivalents per liter, led to an early withdrawal of 11 patients. But this study provides evidence on reduction in proteinuria, but not on kidney progression. The renal protection of optimal antiproteinuric doses route study was performed to determine whether titration of benazepril or losartan to optimal antiproteinuric doses would safely improve the renal outcome in chronic renal disease. A total of 360 patients who didn't have diabetes but they have proteinuria and chronic renal disease were randomized assigned for 4 groups. Patients received open-label treatment with a conventional doses of benazepril 20 mg per day or losartan 100 mg per day, or individual up titration of benazepril or losartan. About in half of patients, optimal antiproteinuric doses coincided with hypertensive dose, but in 40% of patients, optimal antiproteinuric doses surpass hypertensive doses. The primary endpoint was time to the composite of a doubling of the serum creatinine, end-stage renal disease or death. Compared with the conventional doses, optimal antiproteinuric doses of benazepril and losartan that were achieved throughout up titration were associated with a 51 and 53% reduction in the risk of primary endpoint. Optimal antiproteinuric doses of benazepril and losartan achieve a greater reduction in both proteinuria and in the rate of decline in renal function compared with their conventional doses. There were no differences in blood pressure control. Finally, kidney progression was related to dose, but it was not related to the type of the drug. The best results were obtained with optimal doses, regardless whether the treatment was ACE inhibitor or ARB, and the worst results were obtained with conventional doses, regardless if the treatment were ACE inhibitor or ARB. And the next question. The inhibition of RAS system at several different steps of the pathway would lead to a more complete inhibition and therefore to a maximize the renoprotective effect of RAS blockade. Combination therapy with ACE inhibitor and ARBs decrease proteinuria. However, its safety and effect on the progression of kidney disease are uncertain. Patients with type 2 diabetes, a urinary albumin-to-creatinine ratio of at least 300 and stage 2 or 3 CKD patients in treatment with losartan were randomized assigned to receive lisinopril or placebo. The primary endpoint was the first occurrence of a change in the estimated GFR. The study was stopped early owing to a safety concern. Combination therapy with an ACE inhibitor and an ARB was associated with an increased risk of adverse events among patients with diabetic nephropathy. Hyperkalemia and acute kidney failure were the most frequent adverse events. Until this point was reached, combination therapy didn't provide a significant benefit with respect to the primary endpoint, renal progression and death. The results of this trial are generally consistent with those of OnTarget and Altitude, which saw increased harms and no cardiovascular or renal benefit with combination therapies that block the renin-angiotensin system. The results of these two huge clinical trials, OnTarget and Nephro-D, partially disagree with these Spanish clinical trials. Of course, this is a modest clinical trial with a lower number of patients included. This is a multi-center open-label randomized controlled trial to compare the efficacy of combining the lisinopril and irbesartan with that of each drug in monotherapy in slowing the progression of type 2 diabetic nephropathy. I would like to highlight some aspects that maybe they help us to understand some different results. The used doses in this study was equipotent between the groups. In the previous study, the placebo group was treated with a less intense RAS blockade, so you can find a minor effect in blood pressure and therefore a minor hemodynamic acute renal failure. In this study, unlike previous, doses was carefully titrated, and during the study, the doses could be adjusted by hypotension or hemodynamic intolerance. Proteinuria decreased in both groups without difference between them. There were no significant differences on blood pressure control between groups. The number of adverse events, including hyperkalemia, was similar in all three groups. After a median follow-up of 32 months, 30% of patients in the combination group, 29% in the lisinopril group, and 29% in the irbesartan group reached the primary outcome. There were no significant differences in proteinuria reduction or blood pressure control between groups. The number of adverse events were similar. So, under this condition, high doses of ACE inhibitor or ARB had the same impact on renal survival in diabetic nephropathy patients, and the adverse events were also similar. Next question. All this previous conclusion has been obtained from a general population. Specific populations such as age or advanced CKD population are usually excluded for the clinical trial. So we can use the same conclusion for this population. It's not known whether the benefits from RAS inhibition in proteinuric CKD can be extended to elderly patients, since they are often underrepresented in clinical trials and the risk for experiencing the outcome of interest during their remaining lifetime may be different than for the younger population. This is a simulation study in a retrospective cohort within Department of Veterans Affairs that include almost 800,000 patients over 70 years old. As you can see in the graph, where in vertical axis is represented the number of patients needed to treat to prevent a case of end-stage renal disease, the benefit obtained in older population is similar that in younger population. Real benefit is present when proteinuria is bigger than 1 gram per day, and the benefit is especially greater when GFR is low. In this part, in any case, This study also reminds us that 91% of patients included in this study should be considered as having a low or moderate risk for kidney disease progression, as you can see for higher GFR. And the number of patients necessary to treat to avoid an event was higher than 100. So we should choose very carefully this treatment in other populations in which adverse events are more frequent, of course, and more severe. Another important question is whether the benefit from ACE inhibitor or ARB extends to patients with advanced proteinuria CKD, in which the risk of hyperkalemia is significantly increased. This point was addressed in a study in which 422 patients, Chinese patients with non-diabetic CKD, were assigned to benazepril or placebo on top of a standard of care. The patients were divided in 3 groups regarding their baseline serum creatinine. Group 1 were patients with serum creatinine level between 1.5 to 3 milligrams per deciliters. Group 2 and 3 in green and in purple, patient with advanced CKD and serum creatinine between 3.1 and 5 milligrams per deciliters. The group 1 and the group 2 received benazepril and the group 3 received placebo. The renal progression was slower in group 1, patients with baseline GFR higher and treated with benazepril. Between groups 2 and 3 with advanced CKD, patients treated with benazepril had a positive impact in terms of kidney progression than those patients treated with placebo. The benefit from ACE inhibitors in terms of reaching end-stage kidney disease or doubling of serum creatinine was present even in those patients with advanced CKD, and especially when proteinuria was above 1 gram per day. Serious hyperkalemia was similar when benazepril and placebo. However, the results of this study are not spread to all patients with proteinuric CKD, since the patients were rigorously selected and closely monitored during the study for potassium control, and also dietary intake of potassium was likely lower in Chinese population than in Western patients. And the last question, RAS blockade has any impact beyond hemodynamic effect? Angiotensin II appears to participate in the development of tubulointerstitial fibrosis mediated through one of the angiotensin II type 1 receptors that are present in the glomeruli. Angiotensin II also contributes cytokine and chemokine mediated recruitment of inflammatory cells into the kidney. Overall, this effect can generate profibrotic factors such as TGF-beta, connective tissue growth factor, epidermal growth factor, and other chemokines. In fact, regression of glomerulosclerosis has been observed in mice on RAS blockade, but this phenomenon has not been observed in human beings. Clinical trials have not addressed the question of whether RAS blockade decreases renal fibrosis. Impronetic cohort consisted of nephropathy type 2 diabetes patients, and using biobank samples, we measured different inflammatory molecules. All inflammatory parameters measured, interleukin-6, TNF-alpha, or C-reactin protein, were significantly on the rise when they were compared with healthy population. In this study, we found a strong correlation between all inflammatory molecules. In the graph, you can see a strong relationship between interleukin-6 and C-reactive protein in the first graph, FGF23 in the second, and TNF-alpha in the third graph. These are two different studies performed with longitudinal samples obtained from ProNEDI study. On the left, you can see that patients with the highest level of circulating TNF receptor 1 in red increased the risk of mortality and progression of renal disease when they were compared with medium or lower level of these parameters. On the right, again, the most inflamed patient with the highest level interleukin-6 levels, the third tertile in red, had a minor risk of death or renal progression when they were compared with the medium or lower level. But when we analyze evolution of these parameters before and after RAS blockade has been started, we didn't find any difference between them. So RAS blockade didn't change inflammation in over-diabetic patients. Kidney fibrosis has been reported to be a prognostic factor in CKD progression. Different studies have shown that the assessment of the urinary cough, a stress-induced tubular epithelial-derived profibrotic glycoprotein, may be a potential tubulointerstitial fibrosis biomarker and may identify patients at short and long-term risk of GFR loss. In this study, you can see that the patient in the highest DKK3 levels develop faster renal progression. Again, in Pronedi biobank samples, we measure DKK3 levels before RAS blockade and after at 4 months and 12 months. DKK levels increase at 12 months, indicating that renal fibrosis was spreading. However, RAS blockade treatment didn't reduce DKK3 levels, perhaps indicating that this treatment didn't reduce renal fibrosis. We don't find difference between ACE inhibitor or ARB treatment. We don't know if the fibrosis progression would have been different, slower or faster if patient without RAS blockade. So, in conclusion, higher dose of RAS blockade achieve a bigger impact on renal progression. Higher dose that usually recommended in hypertensive indication could be useful in some patients when they are well tolerated from hemodynamic point of view. ACE inhibitor and IRB, when they are used in equipotential dose, they achieve the same effect and they have same adverse events. Only cough could be present in 50% of patients in ACE inhibitor treatment, and this adverse event is not present with ARB. Dual blockade doesn't have an additional effect, so your target should be achieve maximal tolerated dose with monotherapy or with dual treatment. RAS blockade has still benefit in special populations such as older or advanced CKD population, but you should be aware of potential adverse events in them. They are more frequent and more severe in this population. As far we don't know what part of the beneficial effect is due to hemodynamic effect and what part of the beneficial effect is due to other mechanisms. But we don't have evidence that the non-hemodynamic effect play an important role. Thank you so much for your attention. I will be connected to answer all your interesting questions. Greetings from Madrid. Thank you.
I can start. Well, thank you very much, Gema, for this nice overview of this topic. Are there questions from the audience?
Thank you very much, Gema, for the nice talk. I wonder, you have shown us interesting old studies, and we are now in the era of SGLT2 inhibition, where RAS blockade is part of the standard of care. Do you see any change in the RAS blockade for the future in this setting, where we soon will have SGLT2 inhibition in both non-diabetic kidney disease, but we have had it for several years in diabetic kidney disease? Do you see that RAS blockade will change in this setting? Do we need to increase? Can we increase dose or can we decrease dose?
Okay, I think that in this sense we know all we need about RAS blockade. We know that higher dose, higher positive benefit on renal progression. Otherwise, if the patient tolerates the dose, but in any case, you have to at least attempt um, achieve the highest dose you can, because the benefit on renal progression is bigger. So now, no, in the future, now you can we can say that the higher dose is better for the kidney.
Hi, Gema and Enrique.
Hi.
How are you? Nice to see you and a nice presentation. My question is about the combination of ACE inhibitors or ARB and mineralocorticoid receptor antagonists. This is the other possibility in the future with this patient. Do you have any comments about this?
Okay, I think it's a very interesting question, because the mineral corticoids has a potent effect on renal progression. We know that they are able to reduce proteinuria, and in the Fidelio study they have shown that they slow renal progression. So, of course, mineral corticoids is a very good option to treat proteinuric CKD, diabetic proteinuric CKD, or no proteinuria, or proteinuria no diabetic CKD. So, of course, mineral corticoids is a very good option to treat a patient under these conditions. But the problem to do the combination between ACE inhibitor or ARB and mineral corticoids is the hyperkalemia. Mineral corticoids produce hyperkalemia. Maybe the new mineral corticoids induce less hyperkalemia than the previous mineral corticoids, such as aldactone or whatever, but they produce hyperkalemia, and ARB and ACE inhibitor induce hyperkalemia. So maybe at least until this moment we should be cautelous, and maybe the combination between mineral corticoids and ACE inhibitor or ARB should be in very strict condition of surveillance.
Thank you for a very interesting talk. I also have a question about future treatment. In heart failure and hypertension, there have been quite promising studies investigating ARNIs, angiotensin II receptor blockade, and nephology inhibitors, where they block the breakdown of natriuretic peptide. Do you think that we will see studies where we also investigate ARNIs on kidney diseases, and maybe in combination with an SGLT2 inhibitor?
Maybe. Sorry, can you repeat the question, please?
I can repeat the question. In heart failure studies and also in hypertension, they have seen good effects on a combination drug called ARNI, which is an ARB, and also a nephology inhibitor. And nephology inhibits the breakdown of natriuretic peptides. And are you aware of any ongoing or any studies where ARNIs are used for treatment of kidney disease?
I'm not sure.
Yeah.
I'm not sure if I understand your question. I think you are ask me about spassertan and this kind of drugs than in the endothelin, but in this case, of course, spassertan and other kind of this kind of molecule is a promising type of treatment for proteinuric CKD. They have demonstrated in GFSES that they reduce proteinuria in a very consistent way. The problem of this study was, in my personal point of view, that the author don't distinguish between primary and secondary FSGS. Maybe this is an important point, but in any case, in the study, the drugs achieve a very important reduction in proteinuria. That it is the most important question in this for the patient. And now a new study in EGA nephropathy is ongoing, and the recent results support the result obtained in FSGS study. Sparsentan reduced in a very significantly way the proteinuria in patients with EGA nephropathy. So, of course, I think this kind of drugs will be a promising line of study or promising line of treatment in the next years.
Thank you very much, Gema, for your presentation and for your answering the questions. Thank you very much.
Thank you for all of you, and thank you, Esteban.